have been useful throughout history. And what was interesting for me, although before it was thought that the first adhesives were used in ancient Egypt, we now know that it was long before written history that they were used. So recent investigation has found that Neanderthals were the ones that used adhesives first. That was over 200,000 years ago, and they would use this tar produced from burning birch. So that's the type of tree, and its bark, it was burnt, and then tar was produced, and they used it to adhere the two parts of their tools or weapons, so the wooden handle and the blade made out of stone. And it's been a long way from that to Scotch tape. This is a modern invention, and all the adhesives throughout history were always of natural origin. Only within the last 100 years synthetic materials have been developed, and also synthetic adhesives. And what is interesting is that this is a celluloid tape that is on one side covered with a very small layer of methyl methacrylates, which are actually the same materials that we use in our bonding. And of course, in dentistry, adhesion and adhesives and bonding techniques are even more sophisticated. But what is interesting is that bonding really revolutionized dentistry, and when you Google search bonding, this is images for bonding, this is what you get. And all the search refinement suggestions, almost all of them, are directly connected to dental cases. So you can see here receding gum, dental bonding, orthodontics, bonding in orthodontics, composite resin, then some parent and baby from psychology, but again, then front tooth, tooth gap, cosmetic, chemicals. So bonding is extremely important in dentistry, and it is actually the first association for people when they look for this term. And in orthodontics specifically, before bonding there was bending, and try to imagine fixed appliances without this bonding technique. So this is the ribbon arch appliance by Engel, and also afterwards when he developed the standard edgewise appliance. Before the bonding techniques, it was always bended. It always included placement of separators before bending. It was cumbersome for the clinician and for the patient, very uncomfortable, poorly aesthetic, and also the retention of biofilm was much higher in these cases. And so in the 1960s, these were two orthodontists that completely separately, at the same time, started to develop orthodontic bonding systems, one from the United States and one from Japan, and they had to overcome these problems. So the bonding needed to be performed in a humid environment and had to withstand quite high forces throughout 2 or 3 years of treatment time. And one other thing, once the appliance was removed, the bonding material should also be easily removed, which is still a significant clinical problem. And so this is when the experiment started, and in the 1970s the first materials were actually developed and used clinically. They consisted of methyl methacrylates, and also epoxy resins were experimented with, but they didn't have wide application because of some problems with, they have some toxicity, and they are very yellow always in color, which doesn't have to be a problem in orthodontics, but they weren't developed afterwards for cosmetic dentistry, and all these ones were developed on the basis of research for restorative and cosmetic dentistry. And also bonding was and could be performed still with glass ionomer cements that are superior in fluoride release than adhesives from methyl methacrylates, but they don't show high enough bond strength. So this is the modern adhesive, or modern adhesive technique, and an appliance that is bonded to the teeth. And what we need first is the resin matrix. And why? Because any adhesive first has to be liquid in order to wet the surfaces. This is valid for all adhesives, no matter the application or the industry or the profession. But in such a manner the adhesive withstands small shear movements. But when the shear movements are increased, or it should resist tensile movement, tensile forces, it has to be polymerized and solid. So this resin matrix is used because it can polymerize. It has monomers that at their ends have double carbon bonds and can form long chains. This is something you all already know. But again, even when polymerized, the resin matrix itself is not stiff and hard enough, so it needs a lot of filler to withstand the forces that we talked about, and it is silica glass with addition of some ions if necessary. We will talk about that later. So orthodontic adhesives have a very high content of filler in comparison to regular adhesives in restorative dentistry. And the direct bonding technique you all know. So we etch the surface of the animal so that it, after 30 seconds the surface already doubles, and then the acid is rinsed and primer is applied most often, but we will also talk about this. And this primer can or may not be polymerized at this point. And then the adhesive is placed on the bracket is positioned, and all the excess is removed. So this is the technique that uses light, the light source for activation of the monomers and polymerization, but it is also possible to have chemically cured composites that don't allow for such a long working time when placing brackets. A problem of the light cure technique in metal brackets is which one? What do you think? Yeah, the light doesn't penetrate through the bracket as it does with ceramic brackets. So it is always, this is not a good angle. It should always be at an angle of 30-45 degrees from two sides. So if you cure for 10 seconds in total, do it 5 seconds from one side and 5 seconds from the other. It can be mesial distal or gingival incisal. And however, when cured in such a manner, they do show a degree of conversion that is similar to chemically cured adhesives. And they are easier to work with. And how do we test if the force is high enough? So this is the regular experimental procedure. It is called shear bond strength testing, and a tooth is prepared and a bracket is bonded to it, and then it has to be at a perfect angle in the machine, in the testing machine, so when this piece of the instrument presses, it records the force at which failure occurred. So it resists, and then at one moment it fails. And also clinically, if we want to have, so this has a lot of drawbacks, this type of investigation that I won't go now into. You can see that it is not a perfect simulation of clinical conditions, so clinically it also depends on the position in the mouth, so which tooth, is it in the mandible, in the maxilla, and so on. So clinically we usually use survival test or bond failure tests, and it is in a split mouth study, so we can bond one half of the mouth with one type of adhesive, the other half with another, or even better, we can do it diagonally, so that we have adhesive A here in the maxilla, here in the mandible, and vice versa for the adhesive B. Ideally, these trials should be randomized so that patients are allocated randomly, and they should be blinded also, so that the operator who performs the bonding doesn't know which adhesive is which. And also the one who records the failure shouldn't know the same things. And this is the ARI, so the adhesive remnant index. This is a bracket that we use. It is just 1 millimeter wide because it was cut for an experiment that we did. And this would show an adhesive remnant index of 0 because all the adhesive was actually on the bracket. So we are interested in whether the adhesive, how much adhesive is left on the enamel. So this would be an adhesive remnant index of 0 because none of the adhesive is left on the enamel. It is all on the bracket base. And unfortunately, I think we could probably agree on this, that iatrogenic damage to the enamel after debonding procedures is inevitable. So again, we cannot perform orthodontic treatment without touching the teeth, without affecting the teeth in some manner.
In bone and PDL.
Yeah.
And gingiva.
So we need to bond somehow the elements to the tooth. I think it is still a lot more sparing than bending, and comfortable and aesthetic and all these things. And this is an ARI index of 3, so when all the adhesive is left on the tooth. And you can also see that this distinct print of the bracket mesh of the bracket base. And this can afterwards result in discoloration and biofilm accumulation. So even if you go and remove the most superficial layer, there will always be some adhesive left in the enamel that is not easy to clean up in a sparing manner towards the enamel. So you will probably, with a burr, you will probably remove a surface layer of enamel. And is priming necessary? The primer is the one that actually enhances this adhesion. So it is used, primer is just pure adhesive resin without any filling material, so it is very wet, it is very liquid, it can wet the enamel very well, so it can penetrate all the small porosities in between the enamel prisms, and it enhances the bond strength, but it also results in high ARI index. And so 2 studies that I found were actually randomized controlled trials that tried to investigate whether we really need priming. So a drawback, as we said, is too high forces. So they treated 50 subjects, and they saw that the failure rate without primer was 5.5% and with primer 3.1%. And it was not significant statistically because they powered the study at 5%, but clinically it could still mean a significant difference because you can see that the odds ratio of failure if you do not use a primer is almost, so you had almost a double chance of bond failure if you do not use the primer instead of compared to when you use the primer. And also what is interesting, the factors associated with higher failure rates were younger ages, male patients, and the mandible. So I don't know if you noticed that with boys it's more common. In the mandible it's logical because of the position of the upper cusps. But, and of course younger ages may be due to higher salivation or just that they are not as cooperative as they should be when eating and taking care of their appliance. Okay, so they say that it seems to work overall equally well because they did not find a statistically significant difference, but clinically it could actually mean a significantly higher failure rate if we do not use the primer. And also a similar study, so they had much higher failure rates, which was interesting, 11%, and again without primer it was 15%, and again they said it could be clinically significant, although it is not statistically significant. And one reason why we would like to avoid primer perhaps is also saving chair time. But they found that they only saved 4 seconds per bracket, so it's not very, very significant. And yes, it was also shown that when primer was used, an ARI of 0, so no adhesive left on the tooth, was 50%, while it was much more common if no primer was used. So without primer there was a higher rate of clean, polished enamel surfaces upon bracket removal. And so if we have to use primer, how to deal with the remaining bond, the remaining bonding material, the remaining adhesive. This is a clinical case that they showed. So it is not, from this you cannot see, but it is the same patient at the same moment. It's just that they scratched the label surface with the probe so that they can actually see, you can see these gray areas. This is the bonding material, and then they removed it with the tapered fine diamond burr, and actually used microabrasion. So it is a paste that contains hydrochloric acid for whitening, and silica, very fine silica particles. So they actually remove a very thin superficial layer of enamel that is about 25 micrometers thick. While, and they say it is not clinically significant, so the results are very good. Not a lot of enamel is removed because the thickness of enamel is about 1400 micrometers. And this is the appearance after the procedure, and they said that this appearance that was very shiny and polished remained during the years. And then another problem that we have to deal with regarding to the bonding procedure, or actually in general regarding the fixed appliances, are the white spot lesions that we know can be prevented with antibacterial activity. So we give the patient instructions for good oral hygiene, and we can also tell them to use remineralizing agents, pastes, or gels. But the problem with this approach is that the patient cooperation is either moderate or bad in over 3/4 of patients. So the idea was proposed that maybe the adhesive itself could have contain some materials that would help the remineralization of teeth. And it could be done again either through antibacterial ways or remineralization by itself. And this is a recent study that I found that used a BioGlass filler. This is the BioGlass used in oral surgery also, the same one, which has osteoinductive properties. So it can actually, this one can, bioactive properties, pardon. This can induce the formation of, the spontaneous formation of new hydroxyapatite prisms, because it contains calcium and phosphate ions. And they added silver and zinc in it to increase the antibacterial activity in it. And they found that it has superior properties than Transbond in vitro. So Transbond showed a demineralization immediately next to the bracket, while in this case of their tested material it was 0.2 to 0.3 millimeters away from the bracket. Clinically this is not a significant result, and that is a problem with most of these in vitro studies. And also fluoride ions have been added for 20 years in adhesives, and they showed bond strength that was comparable to conventional adhesives, but their efficiency in remineralization is not yet proven, because it is one thing if you get hard enamel in vitro, but if you have to prove this clinically, and this has not been managed yet. And the third option is ACP, so amorphous calcium phosphate. It is the same substance that these two have, and it is contained in experimental adhesives. We also performed some experiments with it, and also there was a commercial adhesive available, Aegis Ortho, that then they took away from the market because it wasn't working well. It actually showed higher failure rates. So what we found that these adhesives containing fluoride, so this is the control Transbond XT, this is Transbond Plus, which is the equivalent of Transbond XT with the fluoride, and this is light bond with fluoride, and this last one is a resin glass ionomer combination. They showed, so Transbond Plus showed superior ion activity than the other two fluoride containing adhesives. However, this is not a high release altogether. And also, so we thought maybe if they do not release for a long time, we could recharge them. So if the patient put remineralization gels or something on the brackets, the adhesives would incorporate this fluoride and then release it afterwards. But this potential is very, very low, as you can see. So they cannot really be recommended for this purpose. And this is a study that the 3M Unitech lab, so the manufacturer lab, proposed. And you can see here that although this diagram, it looks quite steady throughout time. This is actually 1,000, this is 100, so it goes on the 10th potential. And here it has a 10 times smaller release of ions within the first 15 days maybe. So it doesn't really have a high ion release potential, fluoride ion release potential. When we tested the micro-hardness of the experimental amorphous calcium phosphate composite, you can see that its micro-hardness is so low that it's almost immeasurable, so it was very soft and it is not adequate for clinical use. And also what we noticed that along with the fluoride release, the micro-hardness of these adhesives that contain fluoride decreases. So it could be that they are actually, the structure is, there is a problem with the structure and it is deteriorating throughout time. And one last thing that I wanted to show you, so we don't have, the color is not seen, but this curing time, this is if it's cured for 10 seconds and this is if it is cured for 20 seconds. It is the degree of conversion, so how many of the double bonds in the material actually converted into single bonds. And for trans bonds, so this is something that you can take home perhaps. Trans bond has the same, so the difference is not significant. Polymerization, the conversion rate, if you cure it for 10 or 20 seconds. So 10 seconds for trans bond is enough, but do it in 5 seconds from each side from an angle. If you use all these others, so even trans bond plus, it is significantly higher, the degree of conversion, if it is cured for longer, and for all the other materials like bond that we used down here also, it should be cured for longer, even though they say in the instructions curing for 10 seconds is enough. And this is all with a high power lamp, LED lamp, that we also use here. So what about the white spot lesions? We are not effective in their prevention because the patients do not cooperate. We cannot prevent their incidence with our bonding material. So how do we treat them afterwards? I mean, the problem is that orthodontic treatment with fixed appliances is really correlated with white spot lesions. Some report an incidence of 97%, even that high. And certain authors have also claimed recently that it will be a potential public health problem because more and more people are entering orthodontic treatment, and even more times during their lifetime. So how do we treat them? The first suggestion is just to let it remineralize from saliva after debonding for a certain period of a couple of months, maybe until the next retention control. Then we can do tooth whitening, so just that the remaining enamel is not yellow, so that the contrast is not seen as much. And again, microabrasion could be useful also in these cases in combination with whitening. And finally, so these are all non-invasive treatments. And finally, we can also perform restorative treatment, which is invasive and also more expensive. So just once again to reiterate, orthodontic adhesives with fluoride ions are unlikely to be effective in prevention. They have a low recharge potential. They are a bit higher in price than the conventional ones, and it is more, I think that the experiment started with they had good intentions, but now it is just a marketing ploy, so it is not something that you should look for. Okay. And if you have any questions, I will be happy to answer.
Thank you.